right, so let's do this IV cannulation. Okay, so cannula again. Okay, so what you know is when we are in the hospital in the ward, so you have got a clinical room which has got everything, right? So you will take whatever is required for that particular thing, right? So if you're doing the cannulation, so definitely you should have a cannula with you, right? And make sure you take a couple of cannulas because you may not be able to put it in the first attempt. So there is always a chance that you might be needing another one. So make sure when you start, you get 2-3 cannulas, right? So get the gauze as well, syringe also for the flushing, dagger down, that is very important as well, and sharps bin. Make sure you have got the sharps bin near you. Yellow bin is your standard sharps bin. Yeah, yellow bin is the standard sharps bin. That's the main thing. Yeah, so make sure you have got the sharp bin as well nearby. Yeah, so the video you can definitely see. Now let's go for the scenario. Your FY2 in surgery, patient is 27, diagnosed with a ruptured appendix. Patient underwent a surgery a few hours ago for the appendix. Patient IV cannula is blocked. Talk to the patient, change the IV cannula and discuss the management. Sometimes they say with the examiner. Okay, which management? I don't know. So let's see how it is gonna go. Yeah. What's gonna happen is you'll start the station first of all. Yeah. How can I help you? So patient says, I have got pain. Yeah, I've got pain. Where is the pain? Pain is at surgical site. They will just point towards like, doctor, I've got pain here. Okay. So do you think it is something unusual to have pain at the surgical site? I would say it's completely normal, isn't it? A patient woke up after the surgery and saying, I've got pain at the surgical site, it is absolutely a normal thing. There's nothing to worry about. So should I go in Socrates? To be honest, I won't say that you have to do detailed Socrates here because as we said, it is normal to have pain at the surgical site after the surgery, right? But you can ask a bit like, tell me a bit more and they'll say, doctor, so I just woke up now and I'm just feeling pain, which is okay. It's going anywhere? No, that's fine. If the patient has got anything else, this patient sometimes says, I have got nausea, vomiting as well. Okay. So patient has got pain, patient has got nausea, vomiting as well. And obviously when we have done the surgery just now, I don't think so we can give something orally. And when patient is having nausea, vomiting, we definitely can't give something orally. So this patient is in pain. The aim in this country is patient should not be in pain, no matter what. So you need to give some medications to the patient. Which one, that I will see. So what you will do after that, you have to explain about the cannula, and what you do, you will change the IV cannula. How much history? Very little history. You just need to know patient has got pain, patient has got nausea, vomiting. You can ask a bit about the surgery, as how surgery went. Surgery went fine, doctor, but this pain and nausea, vomiting is killing me. Just help me out with that. Okay, should I go with the past medical history and all? Not needed, actually. Not needed at all. So now what you do, you will explain the cannula that I'm gonna put a thin plastic tube with the help of a needle in one of the vein of your forearm. It's gonna feel like a sharp scratch. I'll be gentle and quick. I may have to do it again if I'm not able to put it in my first attempt. And I'll be gentle and quick at any point of time. If you feel uncomfortable, let me know. I will stop my procedure. Any arm vein preference, any arm soreness, and may I proceed? Yes, doctor. Could you please just roll up your sleeves? That's it. And also, like the task says, patient cannula is blocked. So if the cannula, one arm blocked, so maybe try putting it in the other hand. That would be much, much better. Right. And also in this country, I know many countries, when you change the cannula, I would say when it's blocked. But here we change the cannula after 3 days. That's a routine protocol as well. But this cannula is blocked, so obviously we have to change it maybe before that as well. Okay, so what you do, you make sure you change the cannula, you put the dagger down. So within 6 minutes, make sure you're done with it. So to be honest, history, how much history? And patient is talking to you very comfortably. I mean, he's in pain, but he will be giving the history very quickly. So I mean, 2 minutes of history, and I think 4 minutes should be enough for you to do the cannulation. So within 6 minutes, make sure you are done with that, right? Now, you have to discuss the management with the examiner, and the management is, examiner is asking you some question. Examiner is asking, so what are you gonna give to this patient? Patient is in pain. Patient has got nausea, vomiting as well. So the thing is, they're asking what you are gonna give it to this patient. That's the thing. So now, which painkiller you're gonna give it to this patient? So they will check your knowledge about pain ladder in this scenario, right? So before I go into the management of this, let's have a look at the pain ladder, and then I'll come to this station and we'll see how much understanding you got after discussing that pain ladder. So, first thing that we know is the step one, we start always with our non-opioid analgesics. What are the things we have got in non-opioids? We have got paracetamol, aspirin, NSAIDs, right? So that is something that you can start with. Always we look for if there are any adjuvants or not. What are adjuvants? Adjuvants are not painkillers, but they are helping, they're gonna help in the pain management. That's the main thing. So for example, if patient has got bony pain, you give bisphosphonates. Is it a painkiller? Not really, but it helps in pain management. Sometimes you will see in some patient like when they have got neuropathic pain, you give gabapentin, amitriptyline. For trigeminal neuralgia, you give carbamazepine. Is it a painkiller? No, they are adjuvants, but they help in the pain management. That's the main thing. Yeah. So first thing we usually give is a non-opioid plus minus adjuvant. We look for if there is any adjuvant or not. If patient is still in pain, I will check if the patient is taking the medications as prescribed or not, or if patient is taking the maximum dose of it. And if patient is still in pain, what you do? You go to the step 2. And what you do? You add weak opioids. You add weak opioids. If patient is on paracetamol, still in pain, you will add weak opioids. What you will add? You will add maybe tramadol, or you might be adding codeine. We usually don't give codeine alone. What you do? You give co-codamol. What is co-codamol? It is codeine plus paracetamol. So, if patient is still in pain, what you do? You add weak opioids. Plus minus adjuvant. If patient is taking any adjuvant, just continue with that. If patient is still in pain at this level, patient is still in pain, what you will do? You go to the next ladder. That is your strong opioid. That's your morphine, right? And go for plus minus adjuvant. And also, best analgesia is that analgesia, whether you are giving codeine or you're giving morphine, if you are giving it with non-opioid, that is the best analgesia. What I mean by that, if patient is on morphine, you're adding adjuvants, add paracetamol as well. That is the best analgesia. That is the main thing that we should be doing, right? Other thing that you have got is sometimes you'll say in some scenarios, patient will have lots of concerns about morphine, that morphine has got lots of side effects and all. So, yes, morphine can cause constipation, can cause dry mouth, can cause respiratory depression as well. So there are lots of things they are there, right? So if patient is developing any side effects because of morphine, what you're going to do? Don't change the morphine straight away. What you can do, you can treat the side effects. You can treat the side effects. Or maybe we can change it to diamorphine or change it to oxycodone as well, which has got less side effects as well. Sometimes if patient is saying, I'm fed up of taking tablets, can I give it through syringe driver, subcutaneous route? The thing is, it's not an ideal thing. It's not an ideal thing. Why? Because for a syringe driver, it's a continuous infusion. So what's going to happen? Patient has to be bedridden. So it may not be a good option, right? Another thing that we need to know is a PCA pump. What is it? Patient-controlled analgesia. So sometimes what we do after the surgeries, we give this patient-controlled analgesia as well to the patient. So patient can control it. It has got morphine, and it's a combination, morphine and fentanyl. It's a combination they have got. So whenever patient has got pain, they can press the button and they'll get the medicine. So are we worried about the overdosing when we press it again and again? Not really. So it is controlled by the anesthetist as well. So they will control it like in 1 hour, patient should not get more than this much of amount. So there is no problem, and then you don't have to worry about the overdosing in these cases, right? So that's the main thing that you need to know. Uh, What is this fentanyl patch? Let me just go through that as well very quickly. So fentanyl patch is a patch that you put on the skin and and what's going to happen? You will be getting this pain relief. Usually one fentanyl patch is for 3 days, 72 hours it works. So if I say in this way, fentanyl patch, it works for 72 hours. So for example, this is how I'm putting. So 24 hour, 24 hour, 24. So 72 hours, it's gonna work. But as you're putting it on skin, the problem is it takes fentanyl patch takes 12 to 24 hours to show its effect. Meaning, if you put the fentanyl here, You put the fentanyl here, it is gonna take 12 to 24 hours to show its effect. So it will start working here, for example. But remember one thing, it is gonna work for 72 hours. That's how it is. So what happened is sometime we might overdose this patient. You need to be very careful. So patient took the fentanyl patch here, but it took 12 to 24 hours to show its effect. So make sure when it is completely 72 hours, you don't start giving any other painkillers to the patient, or else you might overdose this patient. So that is something that you need to know for fentanyl patch. And it's a very strong medication as well, right? So that is something that you need to do. So usually what we do, we go up the ladder. But when you have a case like post-op cases, I can't go like this. I usually come like this. I go down the ladder. We start with the strong medication, and then after a day or two or three, you will see patient is getting better. You reduce the amount of painkillers you are giving, and slowly you come down, 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 and you will stop it. That's how it works. So we go up the ladder, but post-op, you come down the ladder as well. So that is what happens. So this patient is in pain. So let's see how much we understood about this pain ladder. So which painkiller you're going to give? This is what if they asked you. So now the thing is, before you give any advice about like I'm going to give this or that, see which painkiller this patient is already taking. Because after the surgery, obviously we must have given something to this patient. It's not going to be like that because it's a post appendix surgery. We understand after the patient is going to walk up, he's going to be in pain. So we must have given something. So you can ask which painkiller this patient has already taken. Another question that you can ask that would be, may I know the vitals of this patient as well? So for example, they gave you the vitals. Vitals are, let me give it to you. The blood pressure is, let's say, 130/70. The pulse rate is, let's say, 95. And saturation, if I say 92. And what else? We have got temperature as well. Yeah, temperature, if I say it is 38. And what else you have got? You have got a respiratory rate as well, which is okay, let's say 80. So that's the thing that they have given it to you. Okay, and which painkiller this patient is taking? So if I tell you this patient is taking, let's write here, morphine, 5 mg every 4 hours. Last dose was given 1 hour ago. That's the history that you have got. So you have got the vitals with you, and you have got like what this patient is already taking. This patient is taking morphine 5 mg every 4 hours. Last dose was given 1 hour ago. This patient is in pain, having nausea, vomiting. What are you going to do at the moment? As simple as that. First thing, so what I'll be giving to this patient, I'll give paracetamol, because what is the best analgesia I told you? If it is given with non-opioids, I'll give paracetamol, IV paracetamol, 1 gram. I can give IV metoclopramide, 10 mg. What else I can give? I will make sure this patient is having fluids as well. And that's it. Examiner asks you, your patient is still in pain. What are you going to do? Another thing that you can give oxygen as well. Sometimes you will see the saturation might be low as well, so give oxygen as well. If your patient is still in pain, what you are going to do? I'll tell my patient that I've just given the painkiller. It will take some time to show its effect. Doctor, it's already been 15-20 minutes. Your patient is still in pain. What are you going to do? What I'll be doing, I'll be keeping an eye on the vitals. I'll be keeping an eye on the vitals. I'll involve my senior as well, and I might consider giving a shot of morphine as well. I'll give morphine in titration. How much? Maybe you can give 5 mg, that's absolutely okay. And I have already informed the senior. I will keep an eye on the vitals as well. Morphine 5 mg. I might give naloxone as well. Naloxone as well. 100 to 200 microgram PRN. PRN is as per the requirement. In case the patient develops any respiratory depression, the staff can give it straight away. That's the thing. Again, please involve the seniors, keep an eye on the vitals, and we can repeat the morphine as well. See, soon after the surgery, you will see the first few hours or first day is critical in terms of pain. And after that, you will see the requirement of painkiller is going to reduce only, isn't it? So if you have to give 1 or 2 extra shots as well for the painkiller, it shouldn't be a problem. But make sure you follow the pain ladder. The first thing that we should be doing is checking what patient is already taking. So we have got many scenarios on pain ladder. First thing that you're going to check is what this patient is already taking, if the patient is taking it regularly or not. And then only you will see what I need to add on this. So this patient is having pain on morphine itself. So I'll add paracetamol, give metoclopramide, give oxygen, give fluids as well. But if patient is still in pain, I'll tell the patient just to wait for some time. If still in pain, I can involve my senior, I'll keep an eye on the vitals as well, and I can give morphine in titration. And I'll give metoclopramide again, maybe. I will make sure fluids are going on as well. I might prescribe naloxone 100 to 200 microgram PRN. As you're talking to the examiner, you can use medical words as well, which is absolutely okay. Right? So that's what we have got in this cannula. Okay. Good. Let's see if you've got any question. In cannulation, QR antenatal is opening in. Not really. Shouldn't be the case, doctor. Just, okay, even if it is opening that way, just check in that the whole list, you have got all the stations. I will check that if there is any problem. Do we take the equipment? Will it not be inside the cubicle? Yes, it will be inside the cubicle, doctor. But I was telling in real life, I mean, we have got a clinical room, so we usually take it from the clinical room and then we go to the patient. So in the exam, what's going to happen? You are in the cubicle, all these instruments that you need might be on the side table. So you just go and get all the instrument and then you come and do the blood sampling on the mannequin. Yeah. This scenario, does it mean already he had an IV line and it's blocked? Or should we ask that or say it's blocked and I'm going to change it? Yeah, you can say that I'm going to change it. That's fine. Yeah, but obviously when you go to the patient, have a minute of chat. What happening? Pain is there, nausea, vomiting is there. Then you're like, yeah, it's blocked. I'll change the candle. I'll take this out and I'll take the new line. That's fine. Then if we start codamol, we should warn the patient about, what is it? Then if we start cocodamol, we should warn the patient about paradamol, right? So it includes already paracetamol. They don't need to take another one. Yeah, okay. I think you're saying if the patient is taking cocodamol, we tell the patient is already having paracetamol. Understood. Yes, you're right. So the patch is 72 hours after it starts to kick in, not from the application. Yes, because skin absorption is 12 to 24 hours and it depends on the patient to patient. One patient might be 12 hours, another patient might be 16 hours, another patient might be 20 hours, but it's going to work for 72 hours. Yeah, understood. Should we give him breakthrough dose or repeat the full morphine dose? I think we answered that. Should we ask the question about what med patient was given from the examiner? Yes, that's what you do. And should we give naloxone only if side effects appear from morphine? Yes, doctor. That's why I'm giving it PRN. PRN means what? SOS means whenever it's required. Yeah. Patient's already on morphine. Why are we giving paracetamol and not codeine? So it means, Dr. Javaria, you didn't understand my pain management. If you're asking this question, see, where is this patient? Patient is already on morphine. So patient is on this step already, on step 3. And what we said, the best analgesia is if you are giving it with non-opioids. So if I'm giving cocodamol, I'm coming to step 2. But patient is in pain. So I will stay in step 3 only. So patient is on morphine. What I can do, I can add paracetamol. Once after a day or two, what's going to happen? Paracetamol and morphine is going to make him feel better and patient is improving. Then what you will do? You will come down the ladder and you may start the patient on cocodamol. And then if patient is feeling okay, you will start the patient on paracetamol. And then what you will do? You'll stop it. That's it. Yeah. So that's what we do. Yeah. I didn't notice the answer about the morphine full dose or breakthrough. If you can repeat the answer quickly. So you can say, I will give the morphine in titration, or If they ask how much, I can give 5 mg again because patient isn't 5 mg. I'll give 5 mg. So that's a breakthrough dose. That's absolutely okay. Yeah. Which color cannula should we take? Which color cannula should we take? So, I mean, it depends on case to case, but it is post surgery, after surgery. So maybe you can go with the maybe blue one. Usually in the exam, they have got only one size, so you shouldn't be worried about that. But in some SimMan station or so, sometimes they ask you which goes because then you need to go for the big one. So maybe you can go for the gray one or so. But in this particular scenario, even you go for the blue one, it's not a problem. Yeah. That's how it is done. So the station is going to revolve a bit around the pain management. Yeah, I hope it makes sense.